Thank you. Alrighty. So I'm just going to time myself so I don't go over. All right, so the lack of mental health resources in remote and rural communities across North America is a significant barrier to treatment access for individuals with substance use problems. So existing data suggests that brief online tools that are grounded in evidence-based therapeutic literature have great potential for addressing this disparity. So the purpose of this poster essentially is that we sought to develop and implement a remotely accessible platform called the Screening, Self-Management, and Referral to Treatment, the SMART platform. So the SMART platform is essentially a cannabis informational resource aimed at young adults in rural areas. So for the methodology, the platform was based on 3 things. One, a scoping review of 247 studies that used brief intervention instruments, as well as 468 studies of brief interventions for substance use. 2, by establishing a reference group of 36 researchers and frontline service providers with expertise in prevention and addiction. And 3, an online survey of 3,600 students' substance use habits. So in terms of the results of the study, this presentation provides an overview of the development of the SMART platform, as well as the results of the survey on substance use habits. So the first thing was a scoping review of screening and brief interventions was completed. The scoping review identified relevant screening instruments, intervention strategies, as well as target populations. So using psychometric data, as well as ease of online administration as criteria, a summary of recommended screening and assessment instruments to use in the SMART platform were developed. The results of the scoping review was used to inform development of the online resource platform, using a collaborative process involving interested members of the Canadian Research Initiative in Substance Misuse, CRISM, which is a national network of researchers, service providers, policymakers, as well as individuals with lived experience of substance use, as well as any other stakeholders, which we call the SMART Working Group. And so the SMART platform is a free online intervention designed to really increase access to mental health resources, as well as supports in rural communities across North America. So the third thing that we did was a population survey, which was developed to solicit feedback from the University of Alberta students, which is a major Canadian university located in Edmonton, Canada. And we wanted to solicit their interest in the SMART platform components. And so survey results indicate that between 26 and 51% of past 6-month cannabis users indicated that they would be very interested in or would definitely access screening tools to determine their cannabis use, general information on cannabis, interactive tools to help them manage substance use problems, as well as locally available treatment resources. And so now I want to do like a really quick walkthrough of this figure 1. If I can zoom in. Okay, awesome. And so this is essentially a conceptual overview of what we wanted the SMART platform to look like. So we wanted to provide honest information on substances, including general information, discussion tools, regionally tailored aggregate data on the patterns of use as well as prevalence. We wanted to provide validated screening tools for accessing problematic use of a variety of substances and alcohol, as well as effective self-directed interventions and links to treatment programs for interested users. So you'll see that essentially up here, this is what the SMART platform looks like right now. If you go to the website, and so conceptually, we wanted the main page to look at cannabis. We'll be developing a future page on opioids and alcohol. You can choose to your audience. So if you're a youth, a young adult, your parents and family, or if you're a service provider, and within that, you can look at like education, which would provide you resources for youth and adults, as well as parents and family. The lower risk cannabis use guidelines are also highlighted. If you're curious about your cannabis use, you can look at screening tools, brief interventions, and referral and treatment. And if you need more assistance, this would be the prevention tools and rubrics. So in conclusion, the SMART platform offers a novel way to address the limitations of primary prevention approaches for cannabis use and offers opportunities for widespread dissemination of secondary prevention efforts. Thank you. Cool.
Does anyone have any questions?
Hey Karen, this is Alan. Seems like a pretty cool tool, and the youth gave you some yes/no answers, or kind of about whether they're interested or they'd use it. Did they give you any qualitative responses about parts of it that they found helpful, or feedback on things they thought would, turn them off or thought would be better?
That's a really good question. And so I remember this was like a massive survey. So I personally wasn't involved in the development of this, so I could check on this, but I suspect that we did provide open-ended questions for them to input what they wanted to look for, because we want this platform to be tailored towards youth and young adults. I suspect that we did get them to come in and give us specific feedback on what they're looking for.
And has it been launched yet?
It has been launched, yes.
Ah, all right. So someone's out there collecting data. Are you part of the group that's collecting data?
Yeah.
Ah, cool.
Yes.
So what are the kind of screening tools that are being used?
I can't remember off the top of my head, but I can assume it's like the Cut It for sure. I can't remember anything else off the top of my head, but I could probably see what the website shows.
Karen, is there a campaign associated with this to get the word out that this tool exists, or what's the dissemination approach for young adults or youth to build awareness around this?
That's a really good question. So because this was built in conjunction with like the registrar's office at the University of Alberta, I know like the U of A is using this tool quite a bit, but it honestly hasn't been promoted as much as we would have liked across Canada, because we do want this to be more of like a national tool, right? So unfortunately, as far as I know, we're not actually actively promoting it right now. We're talking about it a lot in conferences, but that doesn't necessarily target our population, which would be youth and young adults. So if you have any ideas.
Nicole is a communications person.
Yeah,
well,
absolutely.
I mean, it would be like partnerships with health departments or local county level departments, things like that, anywhere that you can draw those connections from or leverage those connections, or sort of your first best bet.
For sure. Like, yeah. Service providers, I think, is a major one that we really need to like target. So I don't know if it's like an issue of grant money right now, potentially.
And social media, and anytime you can then tag other people that you would associate with. So any of those local or broad-based entities at the the county or provincial level, and get them on board, just even on an awareness basis. Those are the types of things that then you can help build that ripple effect.
That's a really good point. Thank you.
Are there any more questions? All right, then up next is Chelsea Pike.
All right. Can everyone see that?
Yeah.
All right. Hi, everyone. My name is Chelsea Pike. I'm a senior at Dartmouth College, and I've been doing research with Dr. Alan Budney and Dr. Mike Sophis for about 1.5 years now, focusing primarily on using social media to better understand cannabis use and its consequences. And this poster reflects my first independent project. So there's a relatively large body of research on the factors that relate to continuing or quitting tobacco cigarette smoking during pregnancy. Some of the best research on this topic actually has been done at UVM by the faculty who run this conference. But the factors that relate to continuing or quitting cannabis during pregnancy have not been explored to the same extent, even though the prevalence of cannabis use in pregnant women is increasing. It was 3.4% in 2002, and it was over double that in 2016. And some studies have found that prenatal cannabis use is linked to adverse outcomes for the baby, such as preterm birth and low birth weight. So identifying risk factors for continued cannabis use during pregnancy might be pretty important. So we developed and conducted an online Qualtrics survey of 296 women who were currently pregnant and who reported using cannabis at least weekly during the 3 months before they became pregnant. And the design in general of our study was modeled off of the cigarette literature and one existing cannabis study. So we asked the women whether they quit, relapsed or reduced, or continued their use of cannabis as usual upon finding out they were pregnant. We also assessed demographics, cannabis and tobacco cigarette use characteristics, perceived risks and benefits of prenatal cannabis use, mental health, and delay discounting, all factors that we thought might be related to continuing or quitting, and that could potentially serve as targets for treatment interventions. And then we looked for significant differences between the three groups: the quitters, the relapsers or reducers, and the continuers. So turning to the results in the middle panel of the poster, you can see that there's generally a dosed response across the three groups. Continuers were generally higher than quitters on risk factors and lower on protective factors. And the relapsers, reducers typically fell somewhere in between. So the variables tended to relate to the three groups how we expected them to. Continuers were less likely to be employed, more likely to have comorbid cigarette use prior to pregnancy, and more likely to report that their pregnancy was unintended compared to quitters. And as you might expect, continued users showed much more severe cannabis use prior to pregnancy compared to those who quit. Continuers were more likely to use cannabis within 30 minutes of waking prior to pregnancy, more likely to be daily users, and more likely to use 4 or more times per day compared to quitters. Some other noteworthy findings were that continuers had significantly higher delay discounting rates compared to quitters. I know most of you probably know what delay discounting is, but for those who don't, it's a measure of impulsivity at its most basic level. Continuers also showed significantly less agreement with the risks of prenatal cannabis use to the baby and believed cannabis use has more benefits for the mother. And this was also pretty consistent with what we expected to find. The table on the top right shows some of the specific beliefs related to risk that we asked about. And across the board, continuers were generally less likely to believe there are adverse effects associated with prenatal cannabis use. The last thing we were wondering about was communications with the medical provider. Overall, only 38% of the women in our survey said they talked to their doctor about prenatal cannabis use, which we thought was quite low. But among those who did talk to their doctor, 94% said the doctor told them to quit. Those were the quitters, and compared to 50% of the continuers who said the doctor recommended quitting. So that was quite a big difference. Continuers were also more likely to report that their doctor had discussed the benefits of prenatal cannabis use. So we don't really know if these are causal factors in their continued use, but it suggests that what the doctor says may be making a difference. And believe it or not, this is the largest survey on risk factors for continued prenatal cannabis use that we could find. The next step for me here is to do a multinomial logistic regression to determine if some of the factors I discussed are more significant than others, and it will also be important to replicate this finding with a larger sample. But we did identify some clear risk factors which could serve as future targets for prevention or intervention strategies. And that's all I have. I can take any questions.
So this is very interesting, Chelsea. Thank you. And it does fall in line with what we see as far as the cigarette smokers, right? Pregnant smokers. The more smoking that they do before pregnancy, the more likely they are to continue smoking. And I can see that cigarette use is also a good predictor of whether they're continuing to use their marijuana, which seems very much in line with that. And you know, seriously, congrats on having such a large sample of pregnant cannabis users. I mean, that definitely is something. Just one question. So you have this intermediate group, the relapsed/reduced group. So why did you end up combining those two groups? I assume these are people that quit and then relapsed, or cut down but never actually quit.
Yes, that's a very good question. The relapsing group ended up being very small. There was only about 33, I think, of them. So we didn't want to make that its own separate group. And we thought fundamentally by relapsing, they stopped using for a while. So like overall, they've reduced their use. It's not quite the same as reducing throughout the whole time, but like fundamentally, they had less use than they would have had if they'd completely continued. So we put them in that category.
Yeah, thank you.
Any more questions? Gotcha. Great presentation. We're going to move on to Dr. Michael Sofis, if I'm saying that right.
You have to unmute.
Close enough. All right. So we know that the potency and the prevalence of both cannabis and cannabis use disorder is rising. And we know that there are some effective treatments, but a lot of them aren't ideal. And overall, even the best treatments are only moderately effective. And so a lot of our work has been focused on trying to target cognitive and decision-making deficits that might be linked with cannabis use. So the first is, Chelsea already talked about, which is delayed discounting. And the second is episodic memory. And it's probably the most robust deficit associated with cannabis use. And essentially, it's the ability to learn or recall sort of past details related to your own personal experiences. And so we wanted to design an intervention wherein we had two different intervention components that we're going to target each of these respectively. And so we essentially modified what's called episodic specificity induction, which is more or less just practicing engaging in episodic memory. And this has been shown to help people come up with more positive and vivid future events while engaging in episodic future thinking. And then what we also did was we sort of prompted them to consider other domains during EFT, what we call domain-specific EFT. So we prompt participants to create and imagine these future events in all these different life domains like social life, leisure, career, health. And we wanted to see if that would reduce discounting and cannabis use to a greater extent than essentially doing a regular EFT or an ERT control group. And ERT is essentially just recent thinking. So just thinking about what just happened. And so we had 90 participants. We assessed cannabis use and discounting and other substance use at baseline. The next day, they all got this episodic specificity training, and then they either got ERT, so episodic recent thinking, the standard EFT, or this domain-specific EFT. And then about a week later, we assessed cannabis use, we assessed cannabis use and delay discounting again. And so essentially, I'm going to go skip right to the results because that's the fun part. And so, oh man, this is not going up. All right. So we see here that participants were essentially creating event ratings while they engaged in each of these conditions. So when you're creating future events or you're creating an event or talking about an event that just happened yesterday in episodic recent thinking, we had them rate how enjoyable, important, exciting, vivid, and realistic each of these were, just to see essentially as like a proxy for episodic memory during the actual intervention. And so generally what we saw was that the EFT and domain-specific EFT here, denoted by the gray and black bars, generally did better than the episodic recent thinking control group in each of these, for each of these factors, with the exception of realistic. Here we have discounting, and discounting essentially the higher up you get on this y-axis, the higher or worse the discounting is, the more maladaptive. And essentially what we saw across these conditions is that they all went down. So we didn't really see any sort of differential effect across conditions on discounting. And then what was interesting though is that when we compared the domain-specific EFT to the regular EFT and ERT, we actually saw some notable decreases in both grams in this graph and days on this graph that were statistically significant. And we found that we tried to look at whether discounting would also mediate this effect, and we did not find that it did using a structural equation model. And so you can see the effect sizes here were moderate and just from a single session. And so we saw that number of days in grams was reduced from a moderate large effect, which was really positive, but discounting really wasn't the answer necessarily, at least in this study, in terms of mediating that effect. One reason could be because the ESI intervention may have decreased discounting for each group. But there's other explanations as well. And so we're currently actually in the IRB's already been approved to do a follow-up session that's gonna repeatedly provide this intervention of the ESI and then the domain-specific EFT right afterwards for 6 straight weeks to see if we get better effects and if we can test some of the mechanisms more carefully. All right, thank you.
Awesome, great presentation. Are there any questions?
Sure. Can you clarify a little bit? I don't know if I missed this, but so what was the purpose of trying to get them to engage in this episodic thinking? Were you trying to overcome the kind of discounting of future time periods by making things more real, or were you trying to provide some sort of positive non-drug related things that they could think about? What was the mechanism there?
Yeah, I mean, primarily it's this line of research started off more on the discounting, so evaluating future events, although somewhat ironically, one of the more plausible accounts of the findings we've gotten so far is that it's more of an alternative non-drug reinforcer type of mechanism that could be going on. It's at least certainly very plausible. The idea though was to change discounting and thereby changing discounting, reduce cannabis use. So what was kind of intriguing is that we did end up reducing cannabis use, at least in this initial session, but we didn't actually differentially change discounting.
So are you going to look more into the possibility of alternative reinforcer as a mechanism in this next round?
So we're probably gonna look at it some. What we're kind of interested in as well is episodic memory during the intervention itself part of the mechanism? In other words, there's a lot of research recently showing that even discounting, but also any other health behavior effects is largely a product of how vivid and how many internal details are actually provided during the EFT. And so I wasn't able to really describe the methods in a lot of detail given the time, but essentially you prompt them to think about these future events and they write sort of qualitatively, right? They write textual responses to these questions what are you going to be doing in a year? So you think about this, who are you going to be with? What are you going to smell, hear, feel, where will you be? All these sort of details. And so the more details that people actually provide, typically the more dramatic the effect is on it, whether it's a health outcome or whether it's delayed discounting. And so
yeah, that's interesting because you could think of it either as it's making it more real and less probabilistic, or it's just the actual vividness of itself, of the thought itself is more clear.
Yeah, I mean, because it could be a reward thing. Yeah, it could be what you're talking about seems a little more like control theory, right? If it's more tangible, psychologically close, right? That makes a lot of sense too. Yeah, these are all.
We know discounting works on various levels. It's not just temporal. Probabilistic is in there too.
Yeah, it gets messy. Yeah, a lot messier than people think.
Any more questions? All right, great presentation. Up next is Julia West.
Hi. Let me share my screen. Okay, great. Can you all see it?
Yep.
Perfect. So hi, everybody. Nice to meet you virtually. My name is Julia West. I am a second year clinical psych pre-doc here at BCBH. My advisor is Andrea Valenti, and we primarily focus on youth and young adult substance use and population level research. So I will get started. So currently, state level evaluations of marijuana policy assume that there is equal policy awareness across the state. And this type of evaluation disregards how subgroups of the state's population might respond differently to changes in marijuana policy. So for example, marijuana users may have a different awareness and behavioral response to these changes compared to non-users. In 2018, Vermont became the first state to legalize marijuana possession for adults over 21 through a legislative process. And as of July 1st that same year, Vermonters 21 and older can legally possess up to an ounce of marijuana, as well as 2 mature plants and 4 immature plants. I always get that wrong, so I want to make sure I got it right. The goal of this study was to identify a more nuanced measure of policy exposure than the year the policy change was implemented to evaluate the changes in Vermont's marijuana policy. So we used knowledge of marijuana policy to assess policy awareness or exposure. And the current study also aimed to identify socio-demographic, cognitive, and behavioral correlates of marijuana policy knowledge in Vermont young adults. So the data for this study were collected in spring 2019, which was almost a year after this policy change was implemented. And the data were collected as part of the Policy and Communication Evaluation Vermont Study, or PACE for short. PACE is a longitudinal online survey study of young Vermonters aged 12 to 25. But the sample for this study was limited to young adults enrolled in PACE because the policy changes only affected legal status for young adults. The current sample consisted of 137 Vermont young adults aged 18 to 25. And participants were asked to select each of the following options that reflected changes to the state's marijuana policy. So these options were legal for anyone to use, legal for people 21 plus to use, may use in public, allowed for medical use, and may own up to 2 plants, and legal to sell. So as you can see here, those who selected only legal for people 21 plus to use and may own up to 2 plants were considered to have correct knowledge of the policy changes. But we also included people who only selected those 2 options, but also selected allowed for medical marijuana use, because we think that the young adults who selected those 3 responses likely read the question as what is currently legal in the state rather than what do these most recent changes reflect. So we wanted to make sure that we were really capturing all of the people who had a good understanding of the current policies in the state. So through bivariate and multivariable analyses, we estimated prevalence ratios for correlations between marijuana policy knowledge and socio-demographics, marijuana use, and harm perceptions. Overall, 1/3 of the sample reported incorrect knowledge of the state's current marijuana policy. And being younger, non-white, male, and having less than a bachelor's degree were inversely correlated with policy knowledge. And then ever and past 30-day marijuana use were positively correlated with policy knowledge. And policy knowledge was less prevalent among young adults who perceived great risk of harm for weekly marijuana use, while those reporting slight risk had higher prevalence of policy knowledge. So I don't know if this is hard to see, but I can try to zoom. I don't know if it'll let me. It won't. But this is the table with socio-demographics. This is showing the differences with ever and past 30-day marijuana use by incorrect and correct knowledge. And then over here by incorrect and correct knowledge, you can see responses to the question about regular marijuana use, risks of harm. So given the high proportion of young adults who misunderstood Vermont marijuana policy, policy knowledge might be a more nuanced measure of exposure than the year of implementation. So it might be a better way to kind of identify those differences and subgroups of the population. and also the high prevalence of policy knowledge among past 30-day marijuana users and those with low perceived risk of regular marijuana use signal like novel opportunities for state level education on marijuana to ensure that young people understand the potential harms of using marijuana. And yeah, I think like another really cool thing about this is that I totally lost my train of thought. Oh no. Anyway, if anybody has questions, I said a lot of things, and if I remember it, I'll get back to it.
I had a question. So we did a little bit of stuff on risk perception, and in one of the studies we asked people more about like how positive or like the benefit of it, just because we were in part curious. And this was like a bunch of monthly or past month users that typically were closer to every day than they were to one day a month. And they more or less, almost all of them, I mean like 90% of them or something, said that they actually thought overall, not just was there no risk, but there was actually of harm, but it was actually much more towards the benefit side on average. Have you seen any data about knowledge or education sort of juxtaposed with that sort of people who actually think it's really healthy for them? Is that, what does it continue to show that same trend where maybe they actually aren't, they get more incorrect knowledge, or do you know anything about that, or have you guys looked at that?
I don't, and that's really, really interesting. We didn't ask, in the study, we didn't ask anything about potential benefits. We're doing, so I forgot to mention this, but these data were collected in the first wave of PACE, and we're now on wave 4, and we're funded through for another 2 waves after wave 4. And we are planning to do a lot more on marijuana policy and use and beliefs. And that would be a really interesting thing for us to add. Yeah, because I hadn't really thought about that. Because there's so, legalization is so new, and the like communications around the harms have been really ineffective. And so it's different from tobacco in that sense that like, or opioids, like opioids are this illicit substance that, I think a lot of people perceive as really scary. And tobacco, at this point, almost everyone knows about the harms or that there are harms. And so I think, yeah, that's a really interesting, marijuana is in this place where there are a lot of, there's a lot of communication about the potential benefits. So it would be really interesting to see like a policy knowledge by benefits, or like if there's a difference there. Totally.
Julia, when you ask about marijuana use in this, are you asking about smoking and vaping, or is it marijuana use inclusive of edibles and of all types of marijuana use?
It's inclusive of all types, all products. Yep. So when we ask the question, it's usually like, have you ever tried marijuana, also known as hashish? And we have like a whole list of other terms that are used. And I think it says in it specifically, like, have you smoked, vaped, or ingested? Yeah, and we actually, in the next waves of PACE, we're going to be asking a lot of questions about vaping, THC, and concentrates, which will be really, really neat to learn more about.
What one cool thing there is, I think this makes sense, is that in your top panel in the results section, among the correct knowledge people, that you have a high percentage that say it's a slight risk. Lower, the incorrect knowledge that say it's a slight risk. So the question is slight risk like the right answer? Like, are the correct knowledge people that they really know about cannabis, and they also know that slight risk is what weekly use is about? I know that's really not the point, but it's kind of like that measurement of risk. What does that mean? And when you kind of look at it this way, they obviously think of it as risk or something. I think it kind of almost gets at Mike's point a little bit, is that we need to do a lot better job at defining risk or benefit or something a little bit more meaningful, so that you know if this really means anything. Because I don't know what the right answer is for weekly marijuana use.
Right.
I mean, it is all relative, and usually it's very informative for trends across time. More and more people think it's less risky, which correlates with more use, but it doesn't really tell you much more than that in terms of what the risks really are.
It kind of ties into a conversation that was going on in one of the earlier sessions, where it was really about what is that group's perception of what risk is, or what does risk mean to the young adults as compared to the older adults.
Yeah, as Mike said, he asked the question a couple different ways, sort of, and you get, pretty different answers and different correlations depending on what it correlates with, depending on how you try to assess perceived risk.
Definitely. And I think the other question to ask is, so we want to know, how much risk is there actually, to kind of compare these perceptions against, but also how much risk do we want people to perceive is another question, right? Because wouldn't they be safer if they perceived great risk, even if it's only moderate risk? And the potential downfall of that.
It's a dangerous road to go down now.
Right, exactly. And then you start talking about, and that's exactly what DARE did in their communications, right? They had people assume that all of these different substances had equal risk, which we obviously know is not the case. And I think also, in tobacco, we tend to ask about harm perceptions in a more detailed fashion. So what is the risk of cancer? What is the risk of cardiovascular disease? And I think, ideally we could get to that point with marijuana where we could ask those more specific questions and have a better idea. But it's hard because it can be used in so many different ways. I mean, similarly to tobacco, right? Where there are people ingesting, there are people smoking, and,
yeah, I mean, there's for a lot of these substances, there's nuance behind what the risks are depending on how they're used and what you're doing. And we just have to figure out how we can get that message across. I mean, we don't want to lose the nuance, and we don't want to treat the public like they can't understand the nuance, because that's how you lose them. They think that you're not telling them the truth, and then why trust science if they're going to lie to you? But it's difficult.
Yeah, and in survey research, you always go for these brief assessments and very few number of questions to assess the construct you're interested in or the behavior. And so you're left with, data that you have to kind of overinterpret or talk about what the implications are, but really it's not clear at all sometimes because you didn't ask the right questions. That's very true of marijuana.
Yeah, absolutely. And so if I show you this is a less pretty but more informative version of what we asked. So we asked about all of these other beliefs, and we only saw differences for negative effects on attention and risk from weekly marijuana use, and then understanding that THC is the substance that gets a person high from marijuana, but there were no differences in who knew, who understood or didn't understand the policy based on any of these other beliefs about its effect on depression, effect on academics, and effect on potentially developing addiction. Sorry, everyone. I wish I could zoom in. I know it's small.
All right, we still have a couple of minutes too. If there's any questions anyone wanted to talk about for any.
Can I ask Chelsea? Can I ask Chelsea a question?
Yes.
Because I forget whether we looked at it or not. You know, the tobacco connection, we asked all these people about their tobacco use too, and tobacco use is a predictor of continued use. But among the quitters, what percentage of do we know what percentage of the quitters, and maybe you presented this, actually also quit tobacco? I know we probably have that, right? Or did we decide we all those questions?
I don't have that data with me, but I know it does exist and I can get you that number, but it's not on the poster and I haven't calculated it yet.
That would be very interesting because yeah, it's the combustion is a lot of what you have to worry about for the prenatal effects. So whether they were quitting both marijuana and cigarettes would be good to know.
Yeah. I think we looked at it a little bit right in the beginning before we realized we had way too
Yeah, we asked whether they quit, reduced, or relapsed or continued, but I don't even think there were that many who did both to begin with.
Right.
So
Yeah, that was the problem. We didn't have that many. We thought we'd have a lot more tobacco cannabis users, and there weren't quite enough to do what we wanted. We were hoping to have 1,000 people, but
you still ended up with the biggest sample though, right?
Yeah.
You all can ask each other questions too if you have any.
Well, to Julia, it'll be interesting to see how effectively doing this study again in a year will be now that Vermont has opened up the recreational market, and how that's going to change people's behaviors and understandings of the law.
Absolutely. Yeah, and I would imagine at the very least more people would be knowledgeable of the law because there's been more time. But you never know. Weirder things have happened.
Yeah, the change happens so rapidly with cannabis that you want data, and everybody wants any data. We have to have data, and so we get quick snapshots of data. But with something that's changing so quickly, how long does it take till you would see some impact? And if you try to do it right away, it's right after, so that's good. But probably most things take a while to take effect. And if you wait too long, then you have something else that came along. So it's very tricky to get good data on it. But what happens again is people report all this research, none of it great, but you kind of just have lots of hypotheses about what's going on, and we have to kind of live with that at the moment. But it's not so satisfying.
No.
You're saying science is imperfect?
I'm just saying the marijuana research is very imperfect. And yes, science is imperfect.
Well, maybe we'll just wrap up with that nice little philosophical nugget.
And it's slow.
Thank you all for bringing your research here and presenting it. I really appreciate getting to see some of the stuff that's going on very recently.
Thank you.
Yeah, and
everyone.
Yeah, and we'll hopefully see you for some of the conference tomorrow.
All right. Thank you.
Bye.
Bye.
Bye.